We are on our final module, the module 2 of week 10. So this is very exciting. We made it. There were some bumps and um, potholes, but we made it here, and I'm hopeful that you have a better understanding of the DSM and the disorders within. Please hold on to this information because you will need it when you get to the assessment class. And you're going to need it throughout your entire career. So we are at module 2 in week 10. So let's get at it. We are talking about the disruptive, impulse control, and conduct disorder in this particular module. The disruptive impulse and conduct issues involve problems with a child's ability to control their emotions as well as their behavior. So basically, we're talking about self-management problems that manifest in behaviors that violate the rights of others or that conflicts with what the social norms and parameters are, or it clashes with an authority figure. Disruptive impulse and conduct disorders tend to be more common in males than they are in females, and generally they have onset in childhood. Okay, so we talked about the neurodevelopmental disorders, which have to have onset in childhood. These generally have onset in childhood, and they're related to personality dimensions where we expect there to be a degree of constraint and disinhibition. So we're talking about oppositional defiant disorder, conduct disorder, kleptomania, intermittent explosive disorder, pyromania or fire starting, and other specified or unspecified. You notice here that I have asterisked oppositional defiant disorder and conduct disorder. Those are the ones that we're going to talk about in more depth. I'm not going to talk about kleptomania. We kind of understand that already, and time. And we understand pyromania, which is fire starting. You're going to look into those on your own in the DSM. So let's begin with oppositional defiant disorder. I have a video here. Of course, it's not going to play, but this particular video, it won't play here in this video lecture, but it will play for you in the slides, which have already been downloaded. This is a scenario of a family sitting down, having dinner, and the young boy in the family is suffering with oppositional defiance. And so you get to see it in action. I like to present videos for these latter disorders because I think it helps to see the disorder and the extent to which it plays out. But I also want you to notice the family, the dynamics, what they do, what they don't do, what they attend to. That gives indication to a number of things, like how long this problem has been occurring, such that individuals stop taking notice, they continue with whatever is going on for them. So I want us to take notice of that. So when you're watching it, just notice what you notice, not only in the child, but the family dynamic as well, because that gives you indication of things that you might want to consider with treatment. Let's look at what oppositional defiant disorder entails. It's going to be that pattern of irritable, angry mood where there is defiant behavior attached to it. and it's happening for at least 6 months with 4 symptoms minimum being displayed with a non-sibling, okay? And it impairs functioning, whether that be social, educational, occupational, okay? So it's a pattern of irritability that has defiance attached to it. We've heard, we've seen in the mood disorders the disruptive mood, right? This is a pattern of behavior, but it has a defiance that is associated with it. And when we're talking about the angry and the irritable, we mean that the person has lost their temper, they're easily annoyed, touchy, they're often angry or resentful. There is a vindictiveness that goes along with the oppositional defiance, where they do things out of spite at least twice within the 6-month period of time. And then there's the other aspect, which is the argumentative and the defiant nature. They often argue with an adult or an authority figure. They defy the rules. They are deliberately annoying, and they blame other people for their behavior. Okay? And this behavior is associated with distress in themselves or others who are in their immediate social context. Now, this disorder, when you think about an oppositional defiant disorder, your mind may go back to, like I mentioned, disruptive mood dysregulation disorder. The context for a disruptive mood dysregulation disorder is mood. Okay, it's that all-out tantrum, the inability to manage mood. Here, the hallmark feature is the defiance. It's a constant pushing against being directed by authority figures, teachers, parents, what have you. Okay? So the difference here is the defiance that presents with the irritability. Okay, it's not just the irritability and a lack of control over how a person emotes, which we would expect in a disruptive mood uh, dysregulation disorder. Okay, this is a temper loss, a vindictiveness, and an argumentativeness that comes out of a defiance in being managed, directed, controlled. Behaviors are occurring outside of any sort of a psychotic episode, right? We can understand that. It's not related to substances. It's not a function of depression or a bipolar condition, right? So it is separate from mood and psychosis. The specifiers here are going to go back to what we understand in terms of severity, the number of symptoms. So, and where the symptoms occur. So if it's mild, the symptoms are occurring in a single setting. If it's moderate, it's occurring in multiple settings. So you could have a child who has oppositional defiant disorder, but only at home. They don't engage like that with their parents. Now, we've talked about how things have to occur in multiple settings. With an oppositional defiant disorder, there is room that it may only happen in a single place. Okay? So mild in terms of a specifier, if it's happening in a single setting, moderate in at least 2 settings, and then 3 if it's 3 or more settings. The individual with this particular disorder doesn't really see themselves the way that they present. They don't assess that they have an anger problem or an irritability issue, or that they're even oppositional. They will often push back and say, no, I'm not. That's not me. That's not what's happening. Okay? Oppositional defiant disorder, or ODD, usually precedes a conduct disorder. Okay? What that means is individuals who have conduct disorder often also had oppositional defiance. Okay? Um, but it doesn't necessarily mean that if you have a child that is oppositional, that they will go on to develop a conduct disorder. Oppositional defiance can be comorbid with anxiety conditions and major depression. Okay? The differentials here are going to be your conduct disorder, your intermittent explosive disorder, your language disorders, your social anxiety disorders, ADHD, depression, or bipolar disorder. Okay, those are going to be the differentials. I won't expand on those because we've talked about each of those except for the intermittent explosive, which you will um, look into, but you're differentiating it from those other conditions. And we understand that differentials are diagnoses that mimic or look alike. Next, I have a video on conduct disorder, and again, it represents the extremeness that goes into a conduct condition. Okay, so again, it won't play here, but you're going to notice the extent to which the anger and the irritability can extend to the point of violating other people and their rights. So watch that, the dynamics of the person, because you're looking to see the symptoms that the DSM talks about, but you're also looking at the video for the purpose of being able to see familial impact, relational impact. So, what do we mean by conduct disorder and conduct issues? We're looking at those repetitive behaviors that violate the rights of others, that disregard societal norms. Okay, so we might be thinking in our minds of antisocial personality disorder. You are right to be thinking about that. That conduct disorder and antisocial personality disorder can be differentials, right? They sort of mimic each other. But the age of onset is what helps to differentiate them, as well as the severity. In an antisocial personality disorder, the severity of the violation extends beyond a conduct disorder. But in order to meet qualification, you need three, only three, out of the 15 criteria. And these need to be present over the last year or the past 12 months, with one criteria happening in the past 6 months. Okay? So we have aggression that is directed toward people or animals. Okay? There's bullying, threatening, intimidation. The person might initiate fights. They may be physically cruel to people, physically cruel to animals. They may use weapons to cause serious harm, not necessarily guns, but sticks or bricks or rocks or things like that. They may steal property, vandalize, okay? And the vandalizing gets down into the destruction of property. So when I talk about the stealing, this isn't like an armed robbery or an armed stealing. Usually they're doing these things when the person isn't present, right? Versus assaulting somebody to then take something. The person may force themselves physically onto other people, even in sexual ways. And then there is the destruction of property, where they are deliberately destroying. Maybe fire setting could be included in that. There is a deceitfulness that also accompanies a conduct disorder, right? So it's an understanding of the rights of others and then an intentional violation of that rights, your space, your choices, okay? So again, breaking into somebody's property, their home, lying to get things that they want. Stealing, again, like I said, without the person present. So it could be something like forgery. I've given it the example. And then other rule violations, staying out late despite knowing that perhaps there is a curfew, running away from home, at least while under some sort of a parental authority, and not running away from home because the child is running from abuse, right? And then truancy, not going to school, defying the attendance of school. Of course, we recognize how this could result in clinically significant impairment socially, educationally, and then occupationally. I don't really care what you think. I don't care that I've hurt you, those sort of things, right? I don't have to listen to you. Different from an oppositional defiance, but similar in that defiance of authority and rules. If we've reached 18 years old, then criteria can be met for an antisocial personality disorder. We don't diagnose an antisocial personality disorder until that time because we don't imagine that the frontal lobe, the prefrontal cortex, has been fully developed, where we could say with certainty that this person understands expectations, social norms, and can engage executive functioning more appropriately. Okay, so the specifiers for conduct disorder would be childhood onset, adolescent onset, or unspecified. So if we're not really sure if it started in adolescence, in the teens, or if it started before that, we'll just say unspecified. We're going to indicate whether or not it comes with some limited prosocial emotions, meaning remorse, empathy, lack of concern, or shallow concern, right? Reduced affect. Those are all the things that we would notice in an antisocial personality disorder. But at the conduct level, we would specify if that is present in the child that we are seeing or the adolescent. Okay. And then we would give severity ratings of mild, meaning they just meet the 3 of the 15 criteria, or moderate, meaning the number of problems and the impact to others is more on an immediate or intermediate level, and then severe if they have most of the criteria for conduct problems, and it results in considerable harm to others. We can imagine that if this has a childhood onset and an early onset, that that's going to lend itself to a worse prognosis, right? And it increases the likelihood that there is criminal behavior that might coincide with that. There are some genetic and environmental factors, of course. We don't have children who just come out of the womb with disregard for others, right? There are circumstances that lead into that. Things like substance use or severe substance use. Even parents who have emotional or mood issues, schizophrenia, a parent with ADHD, or even conduct disorder, right? Those things and the environments that are created can lend themselves to a conduct disorder development. So when I give you the videos to view and even the readings, it's to help you understand the relational context and the development then of conditions like this one. Males who are diagnosed with this disorder may present with more aggressive acting out behaviors like the fighting, vandalism, school discipline problems, things like that. Females may tend to engage behaviors where there is more running away or lying, substance use, and maybe even prostitution, because there is that potential sexual aspect to this disorder. Okay, so hopefully you understand that the presentation may be slightly different in terms of which of the 15 criteria are presented in males versus females. And then I've listed the differentials here for you. Now that you understand differentials, you understand how certain things can mimic other things. Hopefully it makes sense when you're looking at the differential list. Intermittent explosive disorder. This particular disorder is going to be associated with these outbursts in behavior, but it's a failure to manage and control aggressive impulses, whether that's verbal tirades or whether it is physical. Again, we're looking at oppositional defiance, we're looking at disruptive mood dysregulation disorder, and then we're looking at intermittent explosive disorder. On the surface, these could have similarities. I want to go back and draw your attention to the hallmark issue. The hallmark issue here is anger and aggressive impulses that aren't controlled versus mood, which isn't well managed, right? Versus a push against authority and an oppositional defiant disorder. So here we're talking about the impulsiveness that is associated with rage and aggression. The behaviors are impulsive. They are not premeditated in an intermittent explosive disorder. The behaviors are unpredictable, and there can be a trigger, but there doesn't have to be a trigger. But the aggression and the vitriol is disproportionate to whatever the stressor might have been. Intermittent explosive disorder can be diagnosed as early as 6 years old, right? So you would need to be able to see this in action and to understand it different from a disruptive mood. And the outbursts occur twice weekly for at least 3 months. In adults, these sort of things might present as road rage, where there's this unexpected, unpredictable, and disproportionate response. It could present in domestic relationships in terms of domestic violence and property damage. The explosiveness could come out in that way. Of course, we know that relationships are going to suffer with an intermittent explosive circumstance, right? And disrupt family members and the trust between them, particularly with the rage and the violence and the violation of space with physical aggression. It is linked to childhood traumas and can be increased with the use of substances. Now, I just want to pause here to say that a person with intermittent explosive disorder is going to have this issue outside of substances, but substances may exacerbate the intensity. Okay, so this isn't a function of substance intoxication, but it can be made worse because of substance intoxication. Okay, And importantly, these outbursts could occur privately, but they are also often very much private. That meaning a person can come in and share with you that they are having these explosive outbursts that come out of the blue. I did want to put the reference here that I've used a lot throughout the course, and it's the Handbook of Relational Diagnoses and Dysfunctional Family Patterns. I think I have that in the list of readings, but in case I don't have that, I wanted to list it here. So we've gone through the diagnostic conditions, specifically focusing here on oppositional defiant disorder, intermittent explosive disorder, and conduct disorder. And I've given videos for two of those, the ODD and the conduct disorder. So this concludes our slides, our video lectures for this quarter and this class. I hope that you, again, have a better understanding and that it has gotten easier, a bit easier, to understand differentials as opposed to comorbid conditions, and how to distinguish when you're seeing one set of issues over another. Okay, that's going to do it.